We are live now, doctor.
Yeah. Good evening, everyone. Warm welcome to NOI NAADI Season 2.2 Finals. First of all, I thank the President, UC President and UC Secretary for giving us opportunity to conduct this competition. As said, NOI NAADI we derived this term from the ancient book of wisdom and the greatest classic of Tamil language, Tirukural, which has 1330 kurals. Among that, we choose this kural, Noi Nadi, Noi Mudal Nadi, Adu Tanikum Vai Nadi, Vaipet செயல். It means that first we have to diagnose the illness. Then we have to trace its cause. Then seek the proper remedy and apply it with skill. As the name was suitable for our competition of diagnosing the cases correctly and treating it accordingly, we use this as a name. So in last year, March, we conducted the NOI NAADI Season 1. Thanks to Dr. Sonal Kalia, President of UC at the time, she was very much helping us in conducting the session. At the time, the President and the other UC Governing Council also. The organizers were myself along with Dr. Niranjan. He is a comprehensive ophthalmologist at the Nirmal Sai Care Hospital, and Dr. Prasanna V. Ramesh. He is the head of glaucoma services and research at Mahatma Hospital at Trichy, and Dr. Pranesh Ravi. He is the cornea and refractive surgeon at Eye Foundation, Pollachi, and he is the chief of the center. That time we had 33 cases in 4 sessions in the prelims. It ran up to 4 to 5 hours, and along with it we had around 10 to 12 judges, and at last we selected 9 cases for the finals, and it was presented in the next day. This shows the screenshot. The prelims and finals had around total of more than 800 views. The chief guest of honor was Dr. Nirmal Frederick. He was the president-elect of TNOI at that time, and he was very generous, and he sponsored the first prize for the candidate. Next, these were the winners in the last season. Dr. Gajashree, Dr. Priyanka, and Dr. Aishwarya were first 3 prizes, and Dr. Komal, Dr. Hemant, Dr. Mridula, Dr. Niranjana, Dr. Akshaya, and Dr. Aditya got the consolation prizes. And prelim judges were Dr. Amar, Dr. Ashwini, Dr. Deep, Dr. Kavya, Dr. Madan Gopal, Dr. Asif, Dr. Neha, Dr. Obri, and everyone. And final judges were Dr. Aditya, Dr. Avnish, and now we have the NOI NAADI Season 2. And thanks to President Dr. Devakant Mishra and Dr. Nilesh, our secretary, and our Vice President Dr. Karan, and Dr. Aditya, treasurer, and our Joint Secretary Dr. Prasanna, who all were supporting this event. Yesterday we had 3 sessions of 30 cases with 9 judges. It started from 5 o'clock and was lasting till 10 o'clock yesterday evening. This is the screenshot taken yesterday. The session had around almost 250 views till now. Among them, we chose the top 10 for the finalists. And the chief guest for the finalists is the GSI President, Dr. Satyan Sir, as the Director of Satyan Eye Care Hospital. And we have well-renowned judges, Professor Hemanandri ma'am. She was a professor and head of the Department of Uvea and Medical Retina and REOGH. And Professor Malarili ma'am. She was a professor and head of Department of Muthukumaran Medical College. And Professor Dr. Vasanta. She was the past director of REOGH and past president of TNOA. Along with the panelists, So, we have Dr. Geeta, Dr. Asif, Dr. Gunjan, Dr. Deep, Dr. Akshaya, Dr. Shreyas. Thank you. Over to you. Yeah. Now over to Dr. Devakant for his.
So much, Karthikeyan. And after yesterday's marathon session, I congratulate the whole team and congratulate all the winners. And a big gratitude towards our chief guest, Dr. Satyen sir, and all the respected judges, Hemanandini ma'am, Professor Malvizi, Professor Vasantha madam, for taking out time for this initiative. And it has been a wonderful event so far, and the team has put in so much efforts and look forward to the winners. And whoever has reached the finalists and whoever has participated in this event is already a winner in our eyes. So best of luck to the whole team and all the participants. Thank you so much.
Nilesh sir,
Yeah. Hi. Good evening, everyone. Thank you first of all for inviting me to be a part of this amazing event. Yesterday also, I joined in a bit late, but it was very fruitful meeting, very interesting meeting, and a great job by the team. And I would like to thank Satyan sir and all the finalist judges for joining and giving us the honor to host them. I hope that it will be a fruitful evening for them, and they will enjoy judging the young talents, and they will identify few who they can mentor and take forward also. So thank you.
now over to Dr. Prasanna to introduce our chief guest.
Can we have the screen?
Yeah.
Thank you, the UC Governing Council, for this wonderful opportunity. So first, I would like to call upon Dr. Satyen Parthasarathy, the current GSI president. Thank you, sir, for taking time to be here for young ophthalmologists. And this is the second season of NOI NAADI. So we welcome you, sir. So, sir has an experience of over 3 decades in ophthalmology and 20 years in Arvind Eye Care System. Is the president of Glaucoma Society of India, and he has also held several positions in TNOA, GSI, and he is won the most promising research award in the GSI at early 2001, and he has won the best patient care project improvement award in American Glaucoma Society and excellence in patient care experience award from the Federation of Indian Chambers of Commerce and Industry, and the best paper award in Ages 25, and the appreciation award given on Teachers Day by IMA, and Professor V. Velaidam Oration Award by Tambaram Ophthalmic Society, to name a few, along with the prestigious honorary FICO. Welcome you, sir, for this wonderful evening. With that, I would like to introduce the other judges of the evening as well. We have an elite panel of senior ophthalmologists, Dr. Hemanand, Professor academic co-director in charge of diploma in optometry and B-Optom courses. Ma'am has published many articles in various journals, chaired many sessions as speaker in various CMEs, examiner, external as well as internal, and guided many postgraduates. So as Devakant sir told, ma'am has been a mentor in guiding many postgraduate theses and optometry courses and whatnot, including quizzes as well as case presentations. Welcome you, ma'am. Happy to have you here today with us this evening. Yeah, next. And I also like to call upon Dr. K. Vasantha, ma'am, who's also been a past president TNOA and former director RIOGH. He would also presented multiple papers in national and international conferences, and a few chapters, especially in 3 books for postgraduates, Another Dynamic Leader and Astute Teacher. Welcome, Dr. Vasantha, ma'am. We look forward to your expertise today's evening. And last but not the least, our another judge, Dr. Malavili, ma'am, a professor and HOD, SMM, CH, and RI. Ma'am has done her undergraduation in Stanley, post-graduation at DO and MS at RIOGH, where she has been the deputy director and professor and published many papers, case reports, and case series, and many ICs. And she has won the best performer during PSC service, best doctor award by state government in 2019, and team leader for surgical management of post-trachoma sequelae. The trachoma that we recently saw, which is now no more in India. Ma'am was the team leader for surgical management of it at for Nicobar Island at 2020, and team leader for management of ocular mucormycosis in 2021. Thanks a lot to the chief guest as well as the three judges. We'd like to have a few words from our chief guest, Dr. Satyen Parthasarathy, sir, President GSI.
Thank you so much, Prasanna, and Yossi team, the President, Secretary, Treasurer. What a wonderful team of people you have. First of all, what I would like to say is I envy you people. The simple reason is we haven't had a Yossi for us. So I really miss those Yossi days. Probably, I mean, I can see how much of glamour the Yossi has today, not only in India, and I think you have really spread your wings across the globe. So first of all, my hearty congratulations to the entire team of people. It is not see the single person can only be like whatever they are, but as a team, that is how we all grow. So I can see as a team how energetic you people are, and of course we are so proud of you people. So we really want to wish you, and we really want to thank each one of you for your whatever the things you are taken up as a in ophthalmology, as a specialist or a general ophthalmologist. We wish to see that you make India proud, and then we wish to see that you are one of the global leaders. And at this moment, as a GSI president, I would like to say that GSI is also kind of keen or eager that definitely you will have a chance to be a part of our GSI team. And definitely, at least from my side, I can give you that guarantee. Whatever possible that we can do it for the AOC part of it, we will definitely go ahead and do it. And what is that? One thing which gives me a lot of energy is that how many programs you guys are able to do is phenomenal. Just to be at the lighter side, I hope all of you are still working. So 5 hours meeting, and then all our elderly people are seeing OPD and doing surgery, and you guys are just into the academics. This is just to be on the lighter side, okay? So my hearty congratulations, and I don't want to hold you longer. So just go ahead and do this wonderful program. Actually, I was just seeing those slides. Once again, I really envy all of the presenters. Wonderful slides, awesome presentations. I think I'm just not going to cut. Prasanna said, sir, you come in the later part again, but I'm not going to cut my thing. I'm going to listen to all the speakers, and I'm going to learn from all of you guys. So have a wonderful meeting. I'm with you. Anytime, I'm ready to help you out in whatever way I can. Thank you so much for the opportunity.
Thank you, sir. Thank you, sir, for being there for young ophthalmologist as well as for UC as well.
Yes, sir. And sir, just cutting in just 1 minute, we are very grateful that you have told that GSI wants to mentor UOC, and we will within 2 days we have a very energetic joint secretary who will draft a letter and get back to you in 2 days. So we will definitely get back to you, sir, as soon as possible, so that we can take this opportunity. Thank you so much, sir.
Thank you for the thumbs up, sir. It means a lot. And definitely do stay back for questions as well as deliberations and discussions for if anything at all needed. So thank you.
Yeah, I'm there most of the time. I'm there. Yeah.
I think if everyone turns off the camera, means we can take a pic.
Yeah. And next, we have 3 dynamic judges: Malarvili ma'am, Hemanandini ma'am, and Vasanta ma'am. Ma'am, a quick word from all the 3 judges as to what you would expect from the presentation, and a few words of motivation for the young ophthalmologists before we start the session. Over to you, dear ma'ams.
I don't know who's going to start first.
Ma'am, you start.
Probably Vasanta madam can start first because she's the senior most.
Yeah, ma'am. Dr. Vasanta, ma'am, over to you, ma'am.
Thank you, Dr. Hema. I'm very glad that you're doing so much. What Satyan has said, I second that, Prasanna. And as he said, there are wonderful photographs. I've already gone through all the slides, and I'm looking forward to this program. Thank you. Thank you for including me.
Thank you, ma'am. Hema, ma'am.
Yeah, good evening to all of you. Really very happy. As rightly said, like when we were postgraduates, we never had this opportunity. In fact, even we used to rely only on the textbooks, but that is the best method. But you have so many platforms, almost every day you have everything on the online, some webinar, something going on. Really, I feel all the young ophthalmologists and the upcoming ophthalmologists are really gifted because the knowledge is shared very quickly and widely. And I also went through all the presentations, and they had awesome titles, and also the content was too good. Just waiting to see them how they. Thank you.
Thank you, ma'am. Maravili, ma'am.
Evening to one and all present here, and I am really feeling proud to be one of the judges in this UC finals. And I'm really very glad, and the presentations were extremely good. I'm waiting for the presentation to be.
Thank you, dear judges. Thank you, our chief guest, and thank you, our president and secretary, Devakant sir and Nilesh, once again for joining. I hand over the session to Dr. Pranesh to start the proceedings.
Good evening, everybody. Great to be here. So we'll start the session with a case presentation. The first presenter will be Dr. Nupur. Nupur ma'am, you can share your screen.
Yeah.
And thanks to the judges, Satyan sir and UCGC members for being a part. Really, really grateful for having such a insightful people in this podium. Thank you.
Yeah. So I hope my screen is visible and it's on full screen mode. Yeah.
Yes, ma'am.
Yeah. So very good evening, everyone. I'm Dr. Nupur, and today I'll be presenting a case titled Piece the Puzzle. Often you will not know it's there, and why I have titled it so that we'll come to know in the future slides. So these are my acknowledgements. So this is a case of a 9-year-old male child who presented with left eye pain, swelling, discharge near the lower lid since 2 days, and he was on oral and topical antibiotics. He had this recurrent episode since the last 2 years, and syringing was documented patent since 2012. The last one was done in 2015, which was done elsewhere. So the rest of the ocular and the systemic history was within normal limits, was insignificant. The visual acuity was within normal limits in both the eyes. On ocular examination, the child had left eye lower lid swelling, which was tender with matting of eyelashes, as we can see in the external photographs. The rest of the anterior and posterior segment examination was within normal limit. So with this, we reached a clinical diagnosis of left eye, acute and chronic recurrent dacryocystitis with a patent syringing. Now we know that NLD obstruction and dacryocystitis is a vicious cycle. So with NLD obstruction, one would expect the syringe to be not patent. So here came the first piece of a puzzle, which was acute dacryocystitis with patent syringing. We decided to investigate further, and the differentials that we came across were atonic sac, infected ethmoidal air cells, which mimicked acute dacryocystitis, dacryolids, and also certain congenital anomalies of the lacrimal system, like the lacrimal sac diverticulum. So we went into the next piece of the puzzle. We requested for a CT dacryocystogram for the patient, and this is what we found, that there was a filling of the lacrimal sac on the right and the left side, and besides it, left side also showed a extra filling lesion. And with this, we had 2 pieces of puzzle in our place, and this we reached the diagnosis of lacrimal sac diverticulum. So we went through a lot of, there have been few case reports and case series which have been reported in the literature. And with this, the things that we came to know about lacrimal sac diverticulum were that it's an outpouching communicating with the lacrimal sac. The etiology can be congenital, traumatic, or inflammatory, congenital being the most common one. So why does congenital lacrimal sac diverticulum occur? During the 6th week of embryogenesis, when the lacrimal system is forming, the extra cells of ectoderm, they sort of form an outpouching and lead to lacrimal sac diverticulum. So it's also been reported that many patients actually have a lacrimal sac diverticulum, but it is often asymptomatic, hence it goes undetected. Hence my title of the presentation, often you will not know it's there. So congenital lacrimal sac diverticulum, it's asymptomatic, but if it becomes large enough, it can cause various pressure symptoms like tearing and discharge. It's fixed to the deep tissue, but not to the skin. It is tense and fluctuant, but clinically apparent, and it's lateral to the lacrimal sac because that's the only area where it has space to grow. And the cryocystogram is necessary for diagnosis. So coming back to our case, so we went to the next piece of the puzzle. We went ahead with the surgery of the patient, which was a left diverticulectomy under general anesthesia. A tear trough incision was taken. The syringing was initially not patent. The diverticulum was excised from the underlying tissues and the lacrimal sac. And we noted a communication between the diverticulum and the sac, which was then sutured off. And at the end, the syringing was patent. So these are the post-operative pictures. At 3 months post-operative, the patient was asymptomatic. So the excised tissue was sent for histopathology, and the lining was noted to be similar to that of the lacrimal sac, which is stratified columnar epithelium. And with this, this formed the fourth piece of our puzzle. Thus, we had all 4 pieces of a puzzle in place, and the puzzle was solved that we were dealing with a case of lacrimal sac diverticulum. So our take-home messages, puzzle by puzzle, piece by piece, is that acute dacryocystitis with patent syringing. It's a rare, the diverticulum is a rare but important cause of dacryocystitis. Imaging is an important diagnostic tool in suspected case of lacrimal sac diverticulum, that is a CT dacryocystogram. And diverticulectomy may alone suffice, and it prevents the need for a DCR surgery. And what is actually essential for the diagnosis is that the pathology of the cystic wall should be identical to that of the lacrimal sac. So with this, thank you so much. Yeah.
Doctor, I have one question. Can you hear me?
Yes,
you said during the surgery, you decided it was not patent. Maybe I didn't hear properly.
Sorry, ma'am. Sorry.
It was patent initially, and during surgery, you said something like it was not patent. Syringing was not patent.
Yes, ma'am. So it was documented from elsewhere that the syringing was not patent. But when we started the surgery, the syringing, it was documented elsewhere that the syringing was patent. But when we did the surgery, the syringing was not patent. So here, this is a nugget for all of us, that do not rely on the syringing findings from elsewhere. Always rely on your findings. So, so it's also how the syringing is done. It sort of make a difference, ma'am. So,
okay.
Or probably the diverticulum had become large enough when we took up the patient that it had actually caused a functional obstruction of the nasolacrimal duct, which was initially not there. That could be one of the reasons, ma'am, that we found the syringe to be not patent during our surgery. Yes, ma'am.
Very good presentation, doctor.
Thank you so much, ma'am. Thank you.
I have a question.
Yes,
clinically, the swelling seems to be well away from the lacrimal pathway, no?
Yes,
so what made you suspect that it is arising from the lacrimal, that's the lacrimal diverticulum? Generally, it was nowhere near the lacrimal region, no?
Yes.
So what made you suspect that it's coming something connected to the lacrimal system?
Ma'am, so the patient, the child had epiphora, has a history of continuous epiphora. Also the history of, undergoing syringing multiple times. So that sort of thought, and then we requested for a CT, the cryocystogram, just to be sure. So that's the cryocystogram actually clinched the thing for us, that, yes.
The cryocystogram only helped you to arrive at the diagnosis.
Yes,
like.
Yes, yes.
That's a very interesting case. Good presentation.
Thank you, ma'am. Thank
you. It's a very interesting case and very good presentation. It's complete and excellent. I just want to know whether dacryocystography, it is 100% diagnostic, or sometimes it may be negative also.
Ma'am, it would be, it is in most of the case, it is diagnostic. Because you would see an extra filling, that is something which clinches a diagnosis. So you would just know that there is some anomaly in the lacrimal system, but the exact diagnosis of diverticulum, as I mentioned, would be the pathology of the cystic wall should be when you send it for a histopathology. So, so you can also, it could also be a canalicular diverticulum. It could be a sac diverticulum. You would just make out that there is some extra filling lesion which is there on the cryocystogram.
Okay. Most of the times it is noticed during DCR, no? So at that time, if you notice a diverticulum during DCR, before removing taking a flap and all, what's your advice?
So, ma'am, as I mentioned, the diverticulum is quite common in the population. It's just that it's asymptomatic. So, if it's asymptomatic, you can probably just leave the diverticulum as it is, and you proceed with your DCR surgery. But then, if you're doing a DCT surgery, then you have to make sure that you're removing the diverticulum along. Otherwise, that would lead to the sac inflammation would be there.
Thank you.
Because, ma'am, when we do a DCR surgery and you're closing off, when you're opening another communication, so the diverticulum itself would get decompressed. It would not have any place to fill in further. So,
okay,
yes, ma'am.
okay.
So,
Thank you. Thank you.
We welcome the panelists, Dr. Asif sir and Geeta ma'am. If you have any comments, please.
Thank you, Karthik. Not for now. That was a great presentation. Yeah.
thank you.
Okay.
There are no questions from my side as well.
Thank you.
So, ma'am, I'd just like to sort of revise my answer to Raman ma'am. So, probably, ma'am, I have not come across a diverticulum during a DCR surgery. But then if probably I would come across, it would be a good idea to excise the diverticulum and close off the communication. Because diverticulum is one of the known causes of a failed DCR surgery. So, I'd just like to revise my answer for you because I just answered in the flow of thoughts. But then if I come across this, I would probably want to explore the diverticulum, excise that and close up the communication along with the DCR surgery. So I'd just like to revise my answer.
Okay, thank you.
Yes, ma'am. Thank you.
So, thank you, Nupur ma'am. Thank you, teachers. So, can we go to the next presentation, Dr. Arut Priya, madam?
Yeah.
Yeah, your slides are visible, ma'am.
1 second, sir.
Voice also is audible. No issues, ma'am. Take your time.
I'm not able to do the full part.
Play, you can just click on slides.
Sir, I'm not able to do the full screen.
Arun, can you click
You
on
can
the
play,
play?
ma'am. Click on play, ma'am.
1 second, sir.
Yeah,
Yes.
you can start.
Good evening, everyone. I'm going to present case distinguishing congenital versus acquired optic disc based on OCT finding. So the first patient, male patient, 45-year-old, has come for a regular examination. His vision in the both eye was 6.6 with intraocular pressure of 16 and anterior segment was quite a normal. So when you see his fundus picture in both the eyes, inferior temporal area, you can appreciate a white defect along with the inferior RNFL defect. So over this area, so we have done an OCT of this optic nerve. So when we run the OCT over this defect, we could appreciate a deep excavation involving the NRR. So corresponding to that area, we could also see an MRW thinning with an early RNFL thinning. So this patient, again, the posterior pole analysis shows loss of a papillomacular bundle corresponding to that site with an associated GCL loss. As patient was not willing for a field analysis, we took an Hood map. Hood map is nothing but it will predict the probability of a field defect based on the present GCL loss. So the field defect was involving the papillomacular area. So this is a case of an bilateral congenital optic disc pit. So second patient, 48-year female old patient, she has been treated as a normal tension glaucoma with intraocular pressure of 18 and anterior segment was quite a normal. So when you see the fundus picture, right eye shows 0.7 cupping with an inferior RNFL thinning and the left eye shows around 0.8 cupping with a more widened RNFL thinning. So when you have a closer look, inferior pole, you can appreciate a grayish slit-like defect. So when we took an OCT at this site, so when we run over this particular site, so have a close look, there is a discontinuity in the NRR corresponding to this defect. So in the similar site, the MRW shows more deeper thinning with the corresponding RNFL with a complete loss of a GCL involving the inferior quadrant. So the field defect shows deep scotoma involving the fixation. So this is a case of a normal tension glaucoma with a left eye acquired optic disc pit. So optic disc pits are nothing but a solitary gray-white excavation of the optic disc. So congenital occurs as a result of an inadequate closure of the embryonic fissure. Acquired, you will usually seen in a normal tension glaucoma. Etiopathogenesis usually due to an ischemic cause. It also indicates that there might be an past the site of an Drans hemorrhage. So congenital can be an unilateral or bilateral in 15%. In OCT, you can appreciate this well-defined deep excavation. Acquired, the excavation will not be this much shallow compared to the congenital one. So the site will be again in inferotemporal, whereas acquired corresponds to the either a superior or an inferior arcuate fibers. So when you see the MRW and RNFL thinning, in a congenital, it will correspond to the papillomacular bundle, whereas here it will correspond to the superior or the arcuate, superior or inferior RNFL. So usually congenital patient acquired this optic pit will be asymptomatic. Some complications like serous detachment, retinoschisis have been reported. In acquired, they will develop a deep scotoma involving the fixation. So thank you.
Great presentation, ma'am. Over to the judges. Hemanandri, ma'am.
Did you find any associated serous detachments because they are more common with optic disc pit?
No, ma'am. There are that area retinal area was there was no change in the morphology, ma'am. There was
That is
no
in the
detachment.
India, you are saying.
Ma'am?
Yeah, you didn't see anything. You didn't see any.
No fluid accumulations or anything, ma'am. We just saw an RNFL defect with an GCL loss. Other than that, there was no active fluid accumulation or any detachment over that area.
What was the follow-up you're having for this patient?
Ma'am, this patient actually, we asked him to follow every 6 months. He's from the local of Coimbatore only. So we asked him for a 6 months follow-up, ma'am.
Okay, what is the likely chances? You said he also has nerve fiber layer thinning, no? What is the likely chances that it will progress or it will be remain stationary?
Ma'am, if at all there is an associated vitreous traction, he can develop a serous detachment.
No, you said thinning, no? Nerve fiber layer thinning.
Yes, ma'am.
So what was the follow-up you advised the patient?
Actually, we asked for we have given an armsless chart. For follow-up, we have given him armsless chart to look for any, weekly once at least to look for any scotomas if he appreciate. So we explained him like what all the complications he can develop due to this congenital pit.
A good presentation and also a rare case.
Thank you, ma'am.
It's a very good
Have you seen
presentation.
that?
Yes,
Okay.
ma'am. Yeah,
Have
ma'am,
you
please proceed, ma'am.
Have you seen that patient now can see glaucoma patient earlier? I just wanted to know whether there was any progression with this thing. Only one question. You answered that and.
Ma'am, actually we is follow-up is coming. Last year, the similar time only we have taken the thing. So is actually his follow-up is coming, ma'am. So we didn't follow up, but his follow-up is coming in this month. He's actually a doctor. He's a close friend of mine actually. So he didn't personally tell any complaints so far.
Okay. No, I just wanted to know if you had seen him earlier.
No, I have not seen, ma'am. Last year was the first time I have met seen his fundus.
Okay, let Mallory ask her this.
Yeah, usually acquired pits are associated with normal tension glaucoma. And the level also, where is the level exactly?
Ma'am, in the inferior pole, ma'am, exactly.
Actually, it's at the level of lamina fibrosa. Okay, is it within the, usually it will be within the optic cup.
Okay.
Okay, very nice and rare case.
Okay, thank you, ma'am.
Prasna, can I just chip in with few comments?
Yes, sir, please.
Okay. So we all see the congenital pits or the optic pit, I would say, but many of our colleagues may not be really aware of which one is a congenital pit and which one is a acquired pit. So this gives a good idea for us to understand where will you look for. I mean, if you have a pit in the eye, is it a concern for us? First thing, is it a congenital pit that you don't have to really go and keep on looking for the glaucoma sign? So that is one thing. And if you have a congenital pit, then you know what is that you have to look for. A serous detachment, then patient may have a positive scotomas. When you have an acquired pit, that is an indication that the patient possibly has a chance of progression. So you have to keep looking for how much is the progression happening in the normal tension glaucoma, which is kind of difficult to treat these patients. Many times we really may not know the exact cause, though we may have all these theories of vascular theories. But still, it is very difficult for us to pinpoint to say this is the cause and I'm going to treat. So that is the reason why this case is very interesting. That okay, you find out an optic pit, and you see how to see that in the OCT. So once you have a spectralis, these are our spectralis pictures. You can see that how nicely we can pick up that pit. So how you should look for a pit in a congenital pit and a acquired pit, where you should look for and how to look for. That is the reason why this case is kind of really very interesting. So over to you, Prasanna.
Thank you, dear judges. Thank you, Satyan sir, for your valuable comments as well. Any other comments from any of our panelists? If there are no more comments, can we move to the next speaker?
Before that, congratulations to Alpriya.
Thank you.
Thank you, Dr. Aripriya, for an interesting case. We'll move to the next case.
Dr. Disha Agarwal.
Yeah, Dr. Disha
Are you
Agarwal.
there?
Yes, sir.
Yes, Disha. You can share your screen and start your presentation.
Pranesh, you are switching on the timer?
Yeah, I'm switching on the timer. Yeah. Once she does full screen, I'll switch on.
Yeah.
Your screen is visible, madam.
Yeah, shall I start, sir?
Please go.
Yes, you can. Yeah.
A very good evening, one and all. I'll be presenting a case of arthritic AION as an initial presentation of Takayasu arthritis. So we had a case of 31-year-old female patient with no known comorbidities who presented with a complaint of sudden onset painful loss of vision in her left eye for the last 2 weeks, which was associated with left-sided temporal headache. There was no other significant ocular history or any history of previous similar episodes. On further asking, there was no history of episodes of giddiness, neurological weakness, joint pains, or fever. The patient had a history of outside consultation done 2 weeks back, for which some retinal laser was done, but there were no records available for the same. Coming to the ocular examination, the visual acuity in the right eye was 612 and left eye perception of light present with projection of rays inaccurate in 2 quadrants with a grade 3 RAPD present in the left eye. The rest anterior segment was normal. So in the fundus examination, we saw that in the right eye, there was a small disc with microaneurysms present over the posterior pole. And in the left eye, we could see pallid disc edema with 360-degree blurred disc margins with laser marks in the inferior nasal and temporal periphery, which was done elsewhere, as the patient said in the history. So we went ahead and did a fundus fluorescein angiography, which revealed again microaneurysms over the posterior pole in the right eye. And in the left eye, it revealed a filling defect of the disc along with again microaneurysms over the posterior pole. So we basically had a case of young female who had a unilateral painful loss of vision along with headache. And on fundus examination, she had a gross diminution of vision in the left eye with RAPD, with FFA revealing microaneurysms in both eyes and a left-sided pallid disc edema. So we went back and did a general examination, which included blood pressure measurement in all the 4 limbs. In the upper limbs, it was not recordable, both the upper limbs, and in the lower limbs, it was within normal limits. And pulse examination revealed feeble pulses in both the upper limbs and carotid artery. Rest of the general examination and systemic examination were within normal limits with no evidence of pallor as well.
Systemic workup included blood examination, which revealed elevated leukocyte count, platelet count, and then raised ESR, and hemoglobin was also within on the lower side. And a CT angiogram revealed diffuse circumferential long segment thickening and vascular occlusion involving thoracic aorta, left internal carotid and vertebral arteries, and bilateral subclavian arteries. So we had a final diagnosis of both eyes Takayasu retinopathy with left eye arteritic anterior ischemic optic neuropathy with Takayasu arteritis. It basically fulfilled 4 out of the 6 criteria given by American College of Rheumatology 1990 criteria, and ETA score was 15. So the management basically included an immediate immunology workup, including CRP and other immunology markers, CT angiogram, followed by a treatment of intravenous methylprednisolone 1 gram OD, followed by a slow taper. The patient wasn't kept on close follow-up to monitor the other eye as well. Coming to the discussion, Takayasu arteritis is basically a granulomatous large vessel vasculitis involving aorta and its branches, and pulmonary and coronary arteries as well, which is more often seen in the 3rd to 4th decade of life, along with a female predominance. Ocular involvement is seen in 45% of cases, with most common being Takayasu retinopathy. It has also been seen that in 74.6% of cases, ocular involvement is the first presentation leading to the diagnosis of Takayasu arteritis, and the patient first presents to an ophthalmologist. So the ocular involvement is basically because of 2 pathologies: involvement of carotid arteries, which leads to hypoperfusion or systemic hypertension. The 4 stages of Takayasu retinopathy are dilatation of small vessels, capillary microaneurysm, AV anastomosis, and ocular ischemic syndrome. So basically, my take-home message will be the importance of detailed fundus examination in cases of disc edema. Like in our case, if we would not have done a close examination with 90 diopter or 78 diopter lens, we might have missed the microaneurysms, which would not have led us to go back and do a detailed systemic examination. Takayasu arteritis, being a multi-system disorder, has varied mode of presentation. That's why important detailed ocular and systemic examination has to be done, and also patient counseling is very important to explain the compliance to treatment and follow-up, since it's a chronic disease which can lead to further deterioration as well. Thank you.
Can you stop sharing, Dr.
Yes, sir.
Over to the judges. Malarvili ma'am, your questions, ma'am.
Was there any improvement after steroids?
No, ma'am. In the left eye, there was no improvement. For the right eye, we have kept the patient on follow-up.
The details of the laser were not there. No? Why was laser done?
Yes, ma'am. We could not get any detail of what was the examination done outside. So we could not get to the bottom of why the laser was done.
Apart from steroids, what else? What else can be given?
Ma'am, if we are not getting any systemic like improvement in the systemic status after steroids, we can start the patient on immunosuppressive agents as well. But as of now, the patient has not been started on like immunosuppressive agents, since the response was there with steroids.
Very good presentation and systematic. That is why you were able to diagnose it.
Thank you, ma'am.
Very nice.
I have a question for you. See, the moment you saw microaneurysms, no, there were only microaneurysms and laser marks.
Yes, ma'am.
So, what was your and a pallid disc edema? So, what was your initial diagnosis? Leave alone arteritis. What would have come to your mind? You never saw any hemorrhages in the fundus?
No, ma'am. There were no hemorrhages in the fundus.
So only microaneurysms.
Yes, ma'am, only microaneurysms. And as soon as we went back and checked the blood pressure, since there was a mismatch in the upper limb and lower limb blood pressure.
Generally, as ophthalmologist, we don't take so much care like physicians to check blood pressure in both the limbs, no? That's what I'm asking you. We don't check it for even in an arthritic AO, in a pallid disc edema.
Yes,
what we do, we look for RAPD, and then we look for other causes. We look for temporal artery, any tenderness, scalp tenderness. We ask for jaw claudication, and then we check the ESR. That's what our how we proceed. But BP we will check, of course, to act as if hypertension could be a comorbid disease causing this. But then to check the BP in both the limbs and in fact upper limbs and lower limbs you had mentioned.
Yes, ma'am.
So
Yes, ma'am.
we need to go in that direction just by seeing the fundus alone.
Ma'am, since it was a young,
Only giant cell arthritis, am I right?
yes, ma'am. Since it was a young patient, giant cell arthritis is common in the older age group. So in the younger age group with a pallid disc edema and temporal headache, we thought Takayasu as the first differential, and that's why we checked the blood pressure in all the 4 limbs.
That's good. Very good. Very methodical examination. Good presentation.
Thank you, ma'am.
Was there any variation in BP between the limbs? That is one of the diagnostic criteria.
In the upper limb and the lower limbs, there was in the upper limbs it was not recordable, and in the lower limbs it was within the normal range. So yeah, as the American College of Rheumatology gives, they tell that there should be more than 10 mm Hg difference in between the upper and lower limbs. So here it was like not recordable in the upper limbs and within normal range in the lower limbs. So that's why that was one of the fulfilled criterias for the diagnosis of Takayasu.
Okay, fine.
Can we move?
Doctor, your title was arthritis AUN, arthritic AUN presenting as Takayasu. That was your title, no?
Yes, ma'am. Arthritic AION as the presenting feature of Takayasu.
So the patient has Takayasu, and that may be the cause also, no?
Sorry, ma'am. Hello. I could not get you.
The Takayasu was present in this patient, and that itself would have been the cause, no?
Yes, ma'am. Basically, I presented the title as such because the patient had did not go for any systemic examination first. The first presentation was to an ophthalmologist since she had sudden loss of vision because of the arthritic AION.
Okay. Okay.
Thank you, dear.
Yeah, hello. I have a quick question for Disha.
Yes, ma'am.
Hello. Yeah.
Yes, ma'am.
Disha, can you give me any other differential for a patient presenting like this with bilateral sudden onset vision loss and disc edema?
Ma'am, you told bilateral sudden diminution?
Yeah, or unilateral sudden diminution of vision with disc edema in a young girl.
Ma'am, in this age, my first differential would be optic neuritis, definitely.
How did you rule that out?
Ma'am, since there was pallid disc edema, there was no history of any neurological weaknesses, and since we did the systemic examination, in the systemic examination, most of it pointed towards Takayasu, so we did not do an MRI to look for any lesions in the brain and spine. That would have been a definite thing to rule out optic neuritis.
But I would have said that, in such a situation, the first BD would be optic neuritis, and it is even in young women, and it can be isolated also.
Yes, ma'am.
Yeah. Okay. I would have liked it if you had said the MRI was also done within that, but that's okay. And if there is no improvement, then you look at arthritic AION and the other diseases. Yeah, but well presented. Thank you.
Thank you, ma'am.
I would like to add a point in optic neuritis, do you have so much of pallid disc edema?
No, ma'am. It will be hyperemic.
Totally against.
Yes, ma'am.
Thank you, dear judges and panel, for a wonderful and enlightening discussion. Thank you, Dr. Disha. Congrats once again for reaching the finals. And if there are no more questions, Pranesh, shall we move to the next speaker?
Yes, we can move to the next speaker. The next speaker would be Dr. Gautam R. Gautam, can you please? Yes.
Can you reset the timer again?
Yeah, let him. Yeah. Are you ready, doctor?
Yes, sir.
Yeah, great. Gautam, you can start. All the best.
I'll be presenting my case, early Parkinsonism, misdiagnosed as ocular myasthenia gravis. Our patient was a woman in her late 60s. She came for a routine checkup post bilateral cataract surgery. Her best corrected visual acuity was 20/20 in both eyes. Her past medical records showed that she had a history of diplopia, for which she was diagnosed with ocular myasthenia gravis, which resolved with oral neostigmine. So the patient was already on tablet neostigmine 15 mg thrice daily for the past 1 year before presenting to us. Coming to the examination findings, there was both eye pseudophakia. Her right eye showed 4.5 millimeter pupil non-reactive to light, and her left eye pupil showed 3 millimeter pupil reacting briskly to both direct and consensual light reflex. When she presented to us, there was no ptosis, and the extraocular movements were full and free in all directions of gaze. Rest of the anterior segment and dilated fundus examination was within normal limit. Gross neurological examination showed no focal neurological deficit. So there was inconsistency with myasthenia gravis because myasthenia gravis typically spares the pupils. So we decided to confirm the diagnosis of ocular myasthenia gravis. Anti-acetylcholine receptor antibodies was negative. MuSK antibodies was negative. Repetitive nerve stimulation showed no decremental response. HRCT thorax showed no evidence of thymus, and thyroid function tests were within normal limits. So we ruled out the diagnosis of ocular myasthenia gravis. Then on further careful physical examination, we noted mild rigidity, slight bradykinesia, and slight tremors. So we got a neurology consultation and we ordered a PRODAT brain scan. This is basically a nuclear medicine scan to assess the dopaminergic function of the brain. This is a normal PRODAT scan showing increased uptake in the basal ganglia. If you notice in our patient, the uptake is reduced, indicating dopaminergic dysfunction. So we confirmed the diagnosis of early Parkinsonism. We decided to do further workup for ocular features of early Parkinsonism. Her blink rate was slightly reduced. Subsequently, her tear film breakup time was also reduced. So she was started on topical lubricant eye drops. She had slower saccadic eye movements compared to a normal person. Her near point of convergence also showed that she had mild convergence insufficiency. Coming to the management, she was initiated on pramipexole 0.25 mg thrice daily. The patient remained stable on this dose and there was no recurrence of diplopia. The key motor symptoms of early Parkinsonism are tremor, bradykinesia, and rigidity. Ocular features include reduced blink rate, difficulty with saccadic eye movements, diplopia, decreased pupil reaction, and they can also rarely present with ptosis. There can also be mild cognitive changes and mood disorders. So the diagnosis of early Parkinsonism is based on clinical examination and response to dopaminergic therapy, and imaging techniques like SPECT can be helpful. Management of early Parkinsonism is with dopaminergic medications like levodopa or pramipexole. So numerous articles have reported cases of Parkinson's disease and myasthenia gravis occurring concurrently in the same patient. In our case, ocular myasthenia gravis was ruled out with comprehensive investigations. By improving neuromuscular transmission and reducing muscle fatigue, oral neostigmine could have alleviated diplopia in our case. However, oral neostigmine also led to several adverse effects in our patient. So the take-home messages are: cases of early Parkinsonism can present to the ophthalmologist first. The ocular features include reduced blink rate, difficulty with saccadic eye movements, diplopia, and decreased pupil reaction. It is necessary to differentiate it from other mimicking ocular conditions, and timely intervention can slow down the progression of Parkinsonism. These are my references. Thank you.
Great presentation, Gautam. Over to the judges. Hema ma'am.
What is the incidence of diplopia in Parkinsonism? Do you comment? Is there patients of diplopia in Parkinsonism at all? Also?
Yes, ma'am. The diplopia in Parkinsonism is mainly because of the convergence insufficiency. And in severe cases, there can be a restriction of extraocular movements. So usually around 10% of the patients with Parkinsonism, established Parkinsonism, can complain of diplopia.
Okay. In fact, neostigmine is not that indicated in Parkinsonism, no? When you diagnose Parkinsonism.
We didn't diagnose Parkinsonism. Actually,
the patient on neostigmine, no?
She was diagnosed as a case of ocular myasthenia gravis, for which she was started on neostigmine. So we suspected something abnormal in our case. So we sent all the investigations for ocular myasthenia gravis, which was ruled out. Then we stopped neostigmine. We started on pramipexole. She was diagnosed in another hospital.
So how is the follow-up? How have you decided the follow-up of this patient? And what is the prognosis?
Yes, ma'am. We started her on pramipexole last month, ma'am, 0.25 mg thrice daily. We decided if she is tolerating or if the symptoms are maintaining, we decided we are planning to hike or reduce the dose of pramipexole. So far, she is doing well on 0.25 mg thrice daily. No recurrence of diplopia.
It's a rare association. Am I right?
Yes. Usually, case reports have reported cases of concurrent occurrence of ocular myasthenia gravis and early Parkinsonism. This case is a case of early Parkinsonism presenting with diplopia.
So the pupil is the pivotal point which helps to differentiate it from myasthenia.
Yes.
Yeah, good presentation. Thank you.
Thank
you. Prasanna, can I just add one comment?
Yes, sir. Please, go ahead, sir.
Okay. Basically, there's one clue you can have is whenever the patient comes with the N6, if you see the near vision, many of them will have N6, but they'll keep on complaining about that they are not able to read properly. So we will be really confused. Why you are saying that N6 you can see, but you are not able to read? So that is one typical complaint whenever you see a Parkinsonism patient, you can just recognize that. So why it is because of the convergence insufficiency. The patient may have a good glasses, but still they will be uncomfortable in reading. So that is one of the things that you should really pick up when you do the examination of a Parkinsonism patient. Not everybody, but quite a good number of them will have this very typically.
Okay.
Thank you.
Thank you, sir. Over to the next judges for their comments. Malarveli ma'am.
Actually, other common problem, what is the other commonest problem like in Parkinsonism? Ocular?
Dry eyes, ma'am. The blink rate will be reduced in them.
Yeah,
so
dry eye.
they have severe dry eyes.
Another one is very common.
That gaze, they will have drooping of face, so they will have difficulty in looking up in severe cases of Parkinsonism.
Actually, visual hallucination is a very common problem with these
people. They will have cognitive changes.
Yes, yeah.
Okay.
Yeah, very nice. Yeah, very nice presentation. Thanks.
Thank you.
After you stopped neostigmin, did you patient had any issues later?
No, ma'am. She for the past 1 year she is not taking neostigmin. Right now there is no recurrence of diplopia or ptosis.
Okay, because both coexist, no, commonly. That's why.
Yes.
Okay. Okay.
Thank you, Tejas, for the kind comments. Yes,
was the patient affected with corona?
No, ma'am. No history of COVID-19 disorder in the patient.
Because I have seen a case with supranuclear palsy, which was diagnosed as Parkinson's.
Oh, okay.
And another neurologist, she's a relative of mine, another neurologist diagnosed that it is a supranuclear palsy.
Okay.
Whatever you said, no, everything was there.
Okay.
Except fever. So that is why I thought that also must be considered.
Okay.
Okay, we'll go to the next case if there's not.
I'll just give one more comment because that is also very important. Whenever you see a patient with multiple sclerosis, Alzheimer's, Parkinsonism, all these patients, you can monitor the progression by looking at the OCT, but I'm not sure about the other OCTs, how it can pick up. But if you have a spectralis, you can really see or monitor these patients' progression. So if you really see the Western, Europe and other countries, they do use OCT to see the progression. So just remember this point also whenever you see these patients. Thank you.
Okay, thank you.
Thank you, Satyan sir. Now we go to the next presenter for the day, Dr. Bijita Deb. Bijita madam, you're there?
Yes.
Yeah, madam, you can share your slides.
Yes. Are my slides visible?
Your slides are visible. Your voice also is audible, ma'am.
Okay. So we'll start. So I'm Dr. Vijita. I'm here to present about corneal perforation managed with Tenon's patch and amniotic membrane graft. I have no financial interest in this particular study. I have a patient of 29-year-old who presented with sudden gross diminution of vision with brownish discoloration of in his right eye. He had associated redness, photophobia, and watering from the same eye. He had no complaints of pain, trauma, or surgery. He, though, gave some vague history of being treated for corneal problem in the same eye for the past 2 to 3 years. He was asymptomatic in his left eye. In his right eye, his vision was found to be hand movements with accurate projection of rays, and his cornea showed a macular scar which was measured around 6 into 4 millimeter in the paracentral area, with a perforation which measured around 2.5 into 3 millimeter with iris prolapse. The perforation was appeared punched out and with no surrounding corneal met. Superficial vascularization was also noted. Examination also showed that he had reduced corneal sensation in his right eye. Left eye was normal. His fundus and gentle B scan were also normal. And then on further querying, we found out he was using a cyclovir eye ointment and moxifloxacin eye drops, though did not have any medical records with him. So at this point, we came to the provisional diagnosis of a long-standing neurotropic cornea with a paracentral corneal perforation with iris prolapse, most likely due to a viral etiology. So these were the investigations that were done, which were all normal. At this point, we planned for a surgical treatment, and it was decided that we would go for a Tenon's patch graft with an amniotic membrane transplant with BCL. He was also explained the need for any surgical procedure. Unfortunately, I don't have the video of the surgery, but we prepared a 4 into 4 millimeter Tenon's patch graft from his superior conjunctiva and trimmed it to the size slightly larger than the size, and we placed it over the perforation and also placed multi-layered AMG over that, and box sutures were applied. We also did an additional surrounding debridement, epithelium debridement before putting the amniotic membrane. And this was at the end of the surgery. The next post-operative day, he looked like that. He had a little bit of photophobia, so not very cooperative for the photograph. So these were the post-operative regimen that was followed for the patient. At the post-operative, all sutures were removed by the end of 3 months, along with the BCL. Patient was continued on topical lubricants. And at the end of 4 months, this is the clinical picture that the patient had. Unaided vision was 624, and best corrected visual acuity improved to 69 parts along with refractive error. He's maintaining this since the last 6 months. So coming to discussion, corneal perforation is a dreaded complication and it needs to be addressed promptly. The cause can vary from infective, non-infective to multiple etiologies. Treatment depends on the size, location, and the etiology of the perforation. And there are multiple modes of managing depending on the size, location, and the etiology. Why we have chosen multi-layered AMG along with Tenon's was it was easily available, low immunogenicity. At the same time, it reduced the vascularity load and also provided volume replacement for the same. So these were the reasons for which we had planned in this patient. And the indications for Tenon's patch graft is slowly evolving, and there are varied areas where we can use Tenon's patch graft with successful results. These are my references. Thank you.
Great presentation, Vijita ma'am. Over to the judges. Hema ma'am.
Can you tell me the size of the perforation?
Yes, ma'am. It was around 2.5 into 3 millimeters.
That also counts, no? Because it's a larger perforation. This Tenon's graft may not provide so much support. No?
Yes, ma'am. Ideally, literature mentions that anything less than 2 millimeter can be managed with glue, BCL, and many above 2, we need anything like Tenon's patch with amniotic membrane.
Yeah, but if it's even more larger, still you prefer Tenon's graft?
No, more than 6 millimeter, it is ideal to go for a penetrating keratoplasty.
What is the reason for this melting, sudden melting?
Pardon, ma'am?
You said, what was the reason for this perforation? You said he's a young patient, no?
Yes, ma'am. He has most likely he had a long-standing viral infection, viral keratitis, and he developed neurotropia. We saw a lot of vascularization, old scars, and even the corneal sensations were reduced in that. So at presentation, his symptoms did not present with severe pain, as we would have expected in a patient who had a perforation like that. He was fairly comfortable.
Yeah, but generally in vascularized corneas, no, very densely vascularized corneas, you don't see so much of perforation. Generally, we don't come across so much perforation. This was relatively, there was a scar and I could see the iris prolapse through that. It was a small opening.
Yes.
So did you investigate the patient for anything else? Did you investigate the patient?
Yes, ma'am. We investigated. Yes, his complete hemogram was done. His immunology profile was done. His seropositivity was checked. All those showed normal. There were no other systemic. Even MAN2 test I had done. Even that was negative. Chest X-ray was also normal.
And the astigmatism also you had mentioned it was some around 1 diopter.
Yes, ma'am. Yes, ma'am.
Final correction, stop correction you had mentioned. Final post-op, 6-9, you had mentioned, no? Post-surgery.
Yes, yes.
He had only one cylinder because the scar appeared irregular and some 70 degrees you had mentioned.
Yes, ma'am. If we see the picture of his pre-operative and post-operative, we can see even the scar has modulated over a period of time. So that's what I had mentioned, that when I was managing the perforation, with the surrounding epithelium also I debrided with a 15 blade. And I intentionally placed a slightly larger amniotic membrane. So what has been seen is amniotic membrane has this, it decreases the immunological load. Also, it decreases the vascularity. So most likely he has improved because of the additional amniotic membrane.
It's a well-managed case. Good presentation.
Thank you so much. Thank you.
Managed the case very well. And since you suspected post-viral, you had put the patient on oral antiviral. No? How long will you continue?
Ma'am, ideally, we can continue it up to 6 months to 1 year. But in my particular patient, I have given for 1 month only, because most likely he presented to me with a ointment and a drop, but he was giving some vague history of being on oral medications also. So I didn't want to overload him with that. At the end of 1 month, when I saw his clinical improvement and there was no additional vascularization or surrounding melt, I stopped his oral cycle.
Okay. Then for monitoring, you didn't have ASOCT. That's because
Unfortunately, it was just the starting of my practice. I did not have ASOCT video recording system at that point of time, ma'am.
Okay. Otherwise, well managed.
Thank you.
Thank you.
The final photograph is really amazing, doctor. I also gave more marks for the management part.
Thank you so much.
Yes, ma'am. I will manage.
How was the corneal sensation after the surgery? Because it is, you said it is viral, and that neurotropic constitution, that corneal sensation is unlikely to recover. No?
His corneal sensations were less, ma'am. It was persistently less, especially over the scar area.
Okay.
I would like to add just one point, madam, I'd like to ask this to Vasanta madam. Like if it's neurotropic means, won't it again melt down, ma'am? Because it's very difficult to treat neurotropic keratopathy.
I actually wanted to ask about that. I didn't want to. I didn't want to give a heart attack to that doctor.
Ma'am,
so it can melt down, no? Like it can recur, no? Because it is going to be neurotropic keratopathy. So the patient needs a constant follow-up because it can occur in some other part of the cornea also.
Definitely, ma'am. And also, herpes infection is known to recur. So he might have a phenotypic. Yes, ma'am. Yes, ma'am.
Because initially, they used to do a central tarsography. I remember as a postgraduate student, and it used to remain for 6 months or so. Because the moment you release the tarsography, again the epithelium will start breaking down. That's what we were taught. Like that's why I asked this question.
But I was fortunate enough that he did not have any complications till now. He's still in follow-up, ma'am.
Thank you.
Thank you.
Thank you, dear judges. And thank you, Dr. Vijita, for a wonderful presentation. So we will move on to the next presenter. So next I would like to call upon Dr. Raj Shekhar Paul. Can you share your screen, Dr. Raj?
Hi, am I audible?
Yeah, you are audible, Dr. Raj.
Is my screen
Yes, visible? Yeah. You can start.
Okay. Good evening, everyone. My topic of today is bubble trouble, a station time. This is a case of 68-year-old female complaining of both eyes diminution of vision and foreign body sensation. On examination, her DCB of the right eye was counting fingers close to face and left eye 20/60. Her IOP was within normal limits and retinal examination showed NPDR changes in both eyes. This is the slit lamp examination, which shows corneal bullae, corneal edema, and ACIOL placed in the eyes, and PI, superior PI, which was patent. The patient had undergone both eyes sequential cataract surgery 20 years ago, and after an alleged history of trauma. She had angle supported ACIOL in her eyes, and right eye was the always less seeing eye. A diagnosis of both eyes pseudophakic bullous keratopathy was made. For symptomatic relief and visual rehabilitation, she was undertaken for DSEC in the right eye, which was a more symptomatic eye. Anterior chamber depth was 3.2 millimeters. Challenges in this eye was that it was a plate loop ACIOL. The superior haptic has passed into the superior iridectomy. And there was a large superior iridectomy shown with the red arrow, which was giving a keratoopia kind of conformation. So DSEC was performed in the presence of ACIOL and the trailing haptic was brought over the iris. The end of the surgery was uneventful with full chamber air bubble tamponade for the graft attachment. But so I thought, we can see in the slit lamp photo, the next day there was less than 1/3 air and the graft was detached. Even in the ASOCT, the detached graft is seen. So my thought process was first to remove the ACIOL and plant a scleral fixated IOL or an iris claw IOL. But it was a more radical surgery and more chances of graft trauma. Expansile gases could have been used, but they cause IOL opacification. Transcorneal anchoring sutures could have been taken, but they are causing graft trauma and suture-related complications. Penetrating keratoplasty would have lost the DSEC donor tissue. Pupilloplasty was what I did. This is this short video showing single pass 4-throw pupilloplasty. So the next day, post rebubbling with pupilloplasty, there was more than half chamber air bubble tamponading the donor disc against the recipient. A strict supine position was maintained for the next 3 days. Figure A and B show the disc attached disc on the day 3. At the end of 8 weeks, well-attached disc with subsidence of stromal edema and bullae, stable ACIOL covering the single but vertically oval pupil with inferior PI patent. Pinhole vision at 8 weeks we did, it was 20/120. To conclude, ill-placed ACLs have been associated with pseudophakic bullous keratopathy. Endothelial keratoplasty in vitrectomized or unicameral eyes is a challenging. Conflicting literature reports over DSEC with retention of well-placed ACIOL and with secondary IOL after removing ACIOL are there. The current patient has been on 8 months follow-up, maintaining stable vision and IOP, and more importantly, being asymptomatic in her right eye. Hence, in this case, the AC bubble was well tamed with a pupilloplasty stitch. Thank you.
Thank you, Dr. Raj. Can you stop sharing screen? Over to you. Malarveli ma'am, Vasanta ma'am. Yes, ma'am.
Why did you think of that pupilloplasty, doctor? I didn't get it.
Ma'am, the air bubble was not staying. It was superior people. It was a superior iodectomy done with an ACIOL. Whenever I was injecting air, it was going into the vitreous through the large pupilloplasty, through the large iodectomy.
Wonderful surgery.
You're so thoughtful and acted well, but you could have planned it earlier itself, no? Because you said that ACIOL, one of the haptic was into the iridectomy, and you had to redial the IOL and all that. You could have done the pupilloplasty earlier itself.
Ma'am, no, ma'am. When I placed the made the complete ACIOL lie on the iris, it was actually covering the pupil part very well. In fact, one of the plate haptic was also covering the superior iodectomy part. I felt I pushed enough air in the first surgery itself, but somehow I miscalculated it on the first surgery. I could have done it on the first go, but it never occurred that the air would have.
Yeah, you were so thoughtful, and the results are good. Very nice. Yeah.
Yeah, we learn by our mistakes.
Yes, ma'am.
Like, what was the post-op vision, post-operative vision after your surgery?
Ma'am, at 2 months we did, ma'am. It was 636.
And it was clear. Cornea was clear.
Ma'am, cornea till date, ma'am, till 8 months it is clear, ma'am.
Till date, it's clear.
Yeah,
What are the because still that ACIOL is in place, no?
Yes, ma'am.
So what do you think? How about the progression of will she develop again?
Ma'am, we are monitoring her IOP. She's currently not on any AGMs. Currently she's maintaining an IOP of around 16 to 18. We are with the applanation tonometry, and we have put her on a single 1 drop of prednisolone, 1% 1 drop daily, along with lubricants. That is all she's at present for the past 3 months she's on. And this has been a stable, and symptomatically also, ma'am, lubricants also she sometimes gives, sometimes not giving in her this eye. She's that much asymptomatic in her right eye.
Anyhow, good presentation for a patient with 160. She has improved so much. So well managed.
Thank you.
Thanks.
Well presented, Dr. Rajsekhar. If we don't have any further questions from the judges,
we can move on to the next speaker.
Yeah, next presenter. Dr. Kirtana.
Slides visible?
Yeah, slides is visible. You can go to full screen and share. Dr. Kirtana, can you start the timer, please?
Good evening, everyone. I'm presenting a case called A Tale of Two Hypersensitivities. So a 15-year-old girl presented to us with redness, diminution of vision, pain, discharge for 3 weeks in the left eye, whitish opacification for 3 days in the left eye, and a small reddish lesion for 3 days in the right eye. She did not give any history of trauma or any systemic complaints. However, on systemic examination, it was found that she was thinly built, had mild pallor, had papules over her forehead and cheeks, and she had these scaly crusted lesions over the bilateral retroauricular areas near the philtrum axillary region, over the waist, and even on her mons pubis. On ocular examination, her visual acuity was 6 parts in the right eye and 636 parts, not improving in the left eye. IOP was within normal limits, and adnexa in the left eye showed mild lid edema. Conjunctiva in the right eye showed mild discharge and congestion. There was a whitish nodule at the limbus taking up stain with surrounding inflammation, whereas in the left eye, there was diffuse congestion. And the cornea on the right eye just showed mild MGD, whereas the left eye showed corneal haze. There were marginal infiltrates. There was a 3.5 into 1.2 mm crescent shaped ulcer with severe stromal loss and punctate staining all over the cornea. There was a clear zone between the limbus and the infiltrates, and the cornea had preserved sensations. The AC was deep and hazy with a 2.5 mm hypopyon, and the rest of the details were not visible. So ultrasound was done because the fundus was not visible, and that was grossly anechoic. So this is the day one photo showing the right eye. The right eye had a small white nodule which took up stain, and it was at the limbus. And this is the left eye. The left eye, as you can see, it shows a very severe looking ulcer with severe stromal loss, and there are marginal infiltrates in the other parts of the cornea as well. This was the ASOCT picture on the first day, which showed 97 micron thickness. And so scraping revealed pus cells. There were no fungal or bacterial elements on the stain, and the treatment was based on provisional diagnosis of right eye flictin and left eye marginal keratitis. So the patient was actually started on tablet ciprofloxacin, and in the right eye, she was given topical gatifloxacin, prednisolone, and hometropin, whereas in the left eye, she also received cyclosporin in addition to the other three medications. We got a dermatological consultation done for the skin rashes, which were diagnosed as atopic dermatitis with impetigo and scabies, and the patient was started on amoxiclav, levocetirizine, ivermectin, fusidic acid, and betamethasone, mupirocin, and because we started her on amoxiclav, the ciprofloxacin was discontinued. When we sent her lab investigations, we noticed that there was hyperchromic microcytic anemia, which was suggestive of iron deficiency, and her inflammatory markers were raised, and her ALP came out to be very severely raised. So we got an ultrasound whole abdomen done, which did not reveal any biliary dilatation. Her KFT was normal, but the calcium was at the low normal level, and phosphorus was low. So we got PTH and vitamin D done, and it was actually vitamin D deficiency leading to secondary hyperparathyroidism. The full rheumatological panel was sent, which came out negative for ANA, ANCA, RF, and ACE, and VDRL viral markers were also negative. A chest X-ray and subsequent HRCT showed that there was post-infective sequelae and no active TB. MAN2 was strongly positive. This was the day three picture. Hypopyon had resolved, and this is day 10. Patient was discharged. You can see signs of healing. And day 10, we actually had 220 micron thickness. This was 1 week follow-up after discharge. This is the right eye and this is the left eye. And her skin lesions had also resolved. So what this case actually taught us was that she had a poor nutrition and environmental background, which led to scabies and impetigo and vitamin D and iron deficiency. All of this led to altered immune dysfunction. And she also had a predisposition to hypersensitivity as indicated by her existing atopic dermatitis. And in India, which is TB endemic, all of these factors together led to her presenting with multiple hypersensitivity reactions, right eye flictin and left eye marginal keratitis. Thank you.
Okay, nice presentation, Dr. Ketan. Over to you, judges.
Very good presentation, actually. And did she have any lung lesions?
We thought that she had a lung lesion, so that is why we got a radiologist opinion and a pulmonologist opinion. Both of them unanimously, they said that whatever changes we are seeing, they're all post-infective sequelae. They said that there was lower lobe segmental bronchiectasis, and that is used post-infective sequelae, no active TB, and no need for treatment for TB as well.
Okay, just wondering, like in this scenarios, no, like she has so much of nutritional component and hypersensitivity. Very unlikely, we don't see, no, because the photograph wise she looks okay, and she doesn't look like person who coming from as you have mentioned environmental factors. So what could be the reasons she has so much of post-auricular lesion, neck, and you have mentioned so many skin impetigo. It's very rare nowadays.
Poor environmental conditions and the socioeconomic status environment, because scabies is usually found in only such environments nowadays. So she had such severe impetigo, scabies, and atopic dermatitis.
Did you rule out any other causes for this sort of immunodeficiency? Let it leave alone impetigo and scabies. Did you do anything else to rule out some hidden causes of immunodeficiency? Because
She
it's
did
very
not have immunodeficiency per se. She had vitamin deficiencies, and she had a predisposition. She had hypersensitivity rather than immunodeficiency.
The ocular manifestation could be due to hypersensitivity, but the disease per se is there should be a reason for all this. No, if leave alone impetigo and scabies or liver function is altered, all these things,
Exactly.
it also comes to a common factor. No, some other foci. So anything else? Any general investigations did you do?
Yes, ma'am. Liver enzymes, out of the 3 liver enzymes, ALT, AST, and ALP, ALT, AST were normal, ALP was high. So that is why we had gotten ultrasound whole abdomen to see whether it was a biliary problem or not. If it was a biliary problem, then it would have shown dilatation of plaques on the ultrasound whole abdomen. But there was no such thing. We had also sent GGT, which is another marker of biliary tract issue, and that also was just at the higher end of normal. So we had gotten endocrine consultation because ALP was high, vitamin D was low, calcium was low normal, and phosphorus was low. And we had sent PTH also. So when we combine all these different markers, we saw that vitamin D was low, PTH was very high, and ALP was high. All of these together happen in vitamin D deficiency, leading to secondary hyperparathyroidism. ALP is also high in vitamin D deficiency. So that was the cause of ALP increase. We were looking for some sort of systemic association, some sort of systemic disorder. So none of it came back positive. We had sent rheumatological investigations also, all of them were negative. So we were actually really looking for something to connect everything, but it was just underlying environment and nutritional deficiency which had actually led to this picture.
And this lectin had disappeared with your topical steroids?
Yes, ma'am.
That's disappeared.
Yes, ma'am.
So what I feel is this ocular problem is mainly secondary to her impetigo and scabies prepared because she has a peripheral marginal keratitis, most probably a staphylococcal infection, which has responded to your treatment. And of course, with your topical steroids, your lectin has disappeared because you know it's only an hypersensitivity. And this hyperparathyroidism might be another issue which you have rightly addressed. That's why complete examination has played a very important role. So good job, very good presentation.
It's an excellent presentation, and you had documented everything and investigated well. You said flictin in one eye. So what is the characteristic feature of flictinular keratitis? I mean, how will the typical feature will be there? Was it present in your case?
Flictin, it can be conjunctival or corneal. So in this case, it was more conjunctival. If it is a corneal flictin, then over time it will sort of march across the cornea, which is very typical of flictin. But since this was a conjunctival flictin, we did not see, and this was her first episode of flictin, so it was not seen.
No, other eye can be flictinular keratoconjunctivitis also, no? Maybe keratitis.
Yes, ma'am, it could be.
So what will be the typical feature in that case, usually? As you said, it will be a marching lesion, no? So the advancing edge will be raised and there will be a lesion of blood vessels. Okay, yeah, but there was no vascularization. Okay, but you are managed very well, yeah.
Just like to add one more point. You actually have the description. It's called fascicular keratitis.
Fascicular ulcer. Yeah, fascicular.
Said shock vessels, no bundle. So usually they ask the exam fascicular keratitis.
Yeah, tongue-shaped ulcer with vascularizations, a typical feature. Okay. Okay. Very nice presentation.
Vasanta ma'am, do you have any further questions?
Yeah, whatever I wanted to ask Dr.
Yeah.
Nandini has asked. Nice presentation.
Oh, okay. Okay, now we can move on to the next presentation, Dr. Mosumi.
Hello, sir. I'm audible.
Yeah, you are audible. You can start your screen share.
Yeah. Is it visible? Hello?
Yes, it's visible. Yeah.
Okay. Yeah, thank you so much, ma'am. Good evening, everyone. I'll be discussing a unique and interesting pattern of choroidal detachment, which was observed post-scleral buckling. Now, as we all know, the most common complication post-scleral buckling is choroidal detachment, and high myopia is one of the most common risk factor because it leads to increased permeability of the choroidal vessels, which further leads to increased exudation of fluid from the choroidal vessels, and this when I can't. Yeah. And this, when associated with compression of the vortex vein by the buccal explant, can lead to choroidal detachment. Now, a 48-year-old male presented with sudden onset, painless, gradually progressive diminution of vision in the left eye for 2 days. There wasn't any similar history in the past, no history of ocular trauma or any other significant systemic history. On ocular examination, right eye had a visual acuity of 6.9 and left eye 6.18 parts. Anterior segment was within normal limits. The right eye fundus had multiple unlasered lattices with holes, and in the left eye, there was a fresh supranasal rhegmatogenous retinal detachment which extended from 2 o'clock position till 6:30 position with multiple unlasered lattices and a superior HST with shallow fovea off. The refractive error in both the eyes was minus 21 diopter spherical with axial length of 32 millimeter. So we planned for laser barrage of lattices in the right eye and scleral buckling in the left eye with drainage. Now, on post-op day 1, to our surprise, we saw a large supratemporal choroidal mount. The break-buckle relationship was adequate, and therefore we plan to manage it conservatively. Now, on post-op day 2, there were further choroidal mounts noted in the infranasal quadrant, and there was partial receding of the supratemporal choroidal mount. On day 4, there was another large choroidal mount, which happened to be in the supranasal quadrant, and by post-op day 7, all the choroidal mounts had started to recede. At post-op 1 month, the retina was well attached with good adequate break-buckle relationship, and all complete resolution of the choroidal mounts were noted with a visual acuity of 6.9. Now, as a surgeon, when we face complication, the first question we ask is, why me, right? So today I thought I'll ask, instead of why did this happen to me, what am I learning right now? So the questions which came to my mind were, why did the waxing and waning pattern of the choroidal mounts occur? And why didn't it appear in the infratemporal quadrant? And how can we prevent this complication? So coming to my first question, a posterior buccal was placed superiorly, traversing 180 degree, which was placed 14 millimeter beyond the muscle insertion, which was pretty beyond. So because of the posterior placement of the buccal, it might have resulted in obstruction of the supratemporal vortex vein. Now let's take a look in the ICG angiography picture. In the right eye, we can see there was increased dye uptake and the prominent ampulla noted in the supratemporal and infratemporal quadrant compared to that of the nasal quadrants. Similarly, in the left eye, we can see there was hypercyanescence in the infratemporal quadrant, and the supratemporal vortex vein is not visible, probably due to obstruction of the vortex vein. Even in the late phase, we can see the prominent dilated ampulla in the infratemporal quadrant. So the location of the supratemporal vortex vein is further away from the optic disc than that of the supranasal and infranasal quadrant. Therefore, it is more prone to obstruction. Further, because of the weakened choroidal vasculature because of myopia, it led to subsequent development of new choroidal mounts. Interestingly, choroidal vasculature has a salient feature of plasticity, and because of the choroidal venous drainage rerouting, the complete resolution of the choroidal mounts occur. Now, the second question is, why didn't it appear in the infratemporal quadrant? Because maximum drainage was taking place by the infratemporal channel, as supported by the Verma et al., that vortex vein ampulla was slightly more frequent in the temporal and inferior quadrants. Now, how can we prevent this complication? Venkatesh et al. Has proposed an idea that we can create a notch in the buccal segment overlying the vortex vein. So my take-home message will be, these are all the factors which can lead to choroidal detachment post-scleral buckling. In our patient, we had all these factors. So in such a case, we should anticipate such a complication beforehand. And even if a complication has occurred, we should not panic and we should look into the pathophysiology behind it. Thank you so much for a patient hearing.
Ma'am, your audio is on mute, I think.
Yeah, sorry. Actually, it's a very good presentation, and in your presentation, you have raised the queries and you have answered it all by yourself. So one thing I want to know is what are the anatomical variations? Is it an anatomical variation which you have mentioned in your ICG?
Ma'am, no, there wasn't any anatomical variation as such. Actually, initially it was thought that vortex vents are one per quadrant. But after the evolution of ICG angiography, we have seen that it's more than that, probably 7 to 8. So, ma'am, important thing is there is a concept of dominant venous drainage per quadrant. So what we saw here also that the temporal quadrant, especially the inferior temporal quadrant, was the dominant venous drainage pathway. And that's why the choroidal mounts didn't occur in that area. And because the patient was highly myopic and because of the very weak fragile choroidal vessels, the choroidal mounts occurred even in the supranasal and infranasal quadrant, though a buckle was not placed there.
If this patient being a myope, there is a variation between the ampulla of superior vortex and inferior vortex.
Yes, ma'am.
What about normal patients in normal axial length? Does the same pathogenesis holds true? In case we have a waxing and waning 3D like this, the same pathogenesis holds true. That also.
Right, ma'am. The pathogenesis remains the same, but because of the scleral rigidity, the choroidal vascular permeability, these things are more altered in myopic patients, which won't be seen in a normal patient. So probably we wouldn't have seen it in a normal eye, which happened in a high myopia.
It's a common complication that follows buckling surgery, no? So more so in a myopic patient, and it's good thing you have followed it up with the ICG so that we have more information and we know why it's like that. It's very good presentation.
Thank you.
Yeah, very good presentation. But one more query you have raised, raised BP. So actually intraoperative rise in systolic BP is one of the cause for choroidal detachment. No? Was the BP monitored and was there any systolic rise in BP?
Ma'am, the BP was monitored both pre-operatively also as well as intraoperatively. There wasn't any. The surgery was uneventful and there wasn't any because the BP machine was already, the BP cuff was already put. So during the surgery. So there wasn't any fluctuation in the blood pressure in this patient. Yes, ma'am.
Patient was put on steroids post-operatively.
Yes, ma'am. Patient was put on steroids.
Okay, fine.
Any other comments from the judges?
So you can go to the next case.
Thank you, Dr. Bhusmi, for an enlightening presentation once again. Thank you, judges. We'll move to the penultimate speaker,
Dr. Shruti.
Shruti Nair.
Good evening, everyone. Are my slides visible?
Your voice is clear, ma'am. You can, no, slides are visible now. You can put it on full screen. You can start your presentation.
Your full screen is missing, Dr. Shruti. It's still not in slideshow.
No.
Yeah, now it's perfect.
Good evening, everyone. Today I'm going to be presenting a case of retinal hemangioblastoma. So 14-year-old boy presented to us with complaints of diminution of vision in the right eye since the past 1.5 years. The child was apparently normal 1.5 years ago when he had gradual, painless, progressive diminution of vision in the right eye. He gave no history of spectacle usage. There was no history of deviation of the eye noticed by the parents and no history of distortion of imaging. He was a single child born of a non-consanguineous marriage, and there was no history of any systemic illnesses in the family, past and personal history for within normal limits. Coming to the general physical examination, it was within normal limits, including the pulse and the blood pressure, which was within normal limits. Systemic examination was normal. There were no focal neurological deficits, and the abdominal examination was soft and there was no tenderness. On ocular examination, head position was erect, facial symmetry was maintained, Hirschberg was orthotropic. The visual acuity in the right eye was 612, while left eye had 6:6 vision. The rest of the anterior segment examination was unremarkable. Pupil reactions were brisk and IOP was within normal limits. Coming to the fundus examination of the right eye, the media was clear. This was normal color. Cup disc ratio of 0.3 was present with RPS to vein ratio of 2:3. There was a reddish orange oval shaped lesion of about 8 to 10 disc diameters located in the superotemporal mid periphery with two prominent dilated and tortuous blood vessels that connected it to the optic disc, which was suggestive of a hemangioblastoma. And this was associated with tractional bands that extended to the macula and tractional detachment just surrounding the lesion with subretinal fluid. The left eye fundus examination showed no significant abnormalities. So to summarize, we had a 14-year-old boy who presented with gradual painless diminution of vision in the right eye with no significant family history and no other systemic complaints. On examination, he had a visual acuity of 612 in the right eye with unremarkable anterior segment examination. And the fundus showed a solitary retinal hemangioblastoma with tractional bands that extended to the macula and tractional detachment that surrounded the lesion with subretinal exudation. So this gave us a clinical diagnosis of right eye solitary retinal capillary hemangioblastoma. So ocular examinations, we did an OCT macula, which showed neurosensory detachment with exudation at the macula. Systemic examinations were done to rule out other systemic associations of the von Hippel-Lindau syndrome, such as cerebellar hemangioblastoma, pheochromocytoma, renal cell carcinoma, and pancreatic. And all of this came out negative. Genetic analysis, however, could not be done as the patient was not affordable for the same. So to treat this exudation at the macula, we gave intravitreal triamcinolone acetonide. And 1 week following the intravitreal triamcinolone, we can see that the subretinal fluid has reduced significantly. Following this, to treat the source of the exudation, we decided to laser the lesion, and frequency double Nd:YAG laser was applied to the lesion as well as to the feeder vessels in a spiraling pattern. Following this, we noticed that there was a reduction in the size of the lesion. However, there was tractional detachment surrounding the lesion with SRF at the fovea, and there was a drop in vision. So we can see the extent of the detachment that has occurred. And on the OCT also, we can see that now there is a combination of tractional detachment associated with exudation of the macula. So in case of combined tractional and exudative detachment associated with the vision drop to hand movements close to face, how did we proceed? We decided to take the patient up for pars plana vitrectomy. Initially, we gave an intravitreal anti-VEGF preoperatively, and PPV was done along with membrane peeling, truncation of membrane surrounding the lesion. Laser was augmented, and SF6 gas was used to settle the detached retina. Following surgery, the retina was attached with no evidence of subretinal fluid, and 3 months later, the vision improved gradually to 6 parts. So the hospital course, initially for exudative detachment, we treated with intravitreal steroids. Following improvement, we ablated the lesion and the feeder vessels, which caused shrinking of the lesion, but increased the traction. And the vision dropped, for which we took the patient up for PPV. And following the PPV, the retina was attached and vision improved to 6:6. So the take-home messages are that retinal detachment due to hemangioblastoma can be exudative or tractional or mixed. If it's exudative, we treat with laser and steroids. If tractional, we go for surgical intervention. However, late tractional detachments are difficult to treat and require both buccal band along with vitrectomy, and multiple surgeries may be needed. Thank you.
Great, Dr. Shruti. Now over to the judges.
Excellent presentation and very good clinical photograph. The fundus photograph was very good, well taken. And if at all you just, the patient's presenting vision was 6/6, am I right?
6/12 in the right eye.
12 in the right eye. So can you just keep the patient on, place him on observation?
6/12, the reason for if the patient was 6/6, we would still treat the lesion if it's peripheral, because there is always a risk of further exudation at the macula, which can cause vision loss. So if a patient presents incidentally also, we will treat and initially apply laser or cryotherapy to the lesion. However, in our case, initially on presentation, there was vision loss, which was attributable to already existing exudation. So initially we treated that. Once that settled down, we decided to treat the source of the exudation.
What was the post-operative intraocular pressure following IVT?
It was normal at all times, ma'am. There was no rise or steroid response that was noted.
What is the role of PDT in such cases?
And PDT has been described, however, we don't have it at our setup, and it's mostly used in case of juxtapapillary lesions.
So anyhow, your vision dropped, and then again you managed to. Yeah, good presentation, very good clinical photograph.
Thank you.
Actually, laser, when is it indicated for such a large lesion with tractional component and exudate, all that? Will you do laser?
Ma'am, actually, we have to treat the source of the exudations, because if we don't treat it and the lesion does not involute, then there will be recurrent exudation that will constantly keep occurring. So we have to treat the cause. So if it's a large peripheral lesion, we can go for cryotherapy. If not, posterior fold, we can go for laser or transpupillary thermotherapy. And some cases of PDT have also been described. And there are cases where they have actually in toto, but that's a very technically demanding procedure, and there's a lot of connections between the retina and choroid. So high risk of bleeding is also present. So that's not commonly done, but it has been described. It's not recommended to leave the lesion untreated.
Okay. But for a larger lesion, you could have gone for surgery itself, no, the initial large lesion with fractional component.
Ma'am, but the traction didn't involve the macula at the time, and in view of good vision, so it was a 6/12 vision and 6/6. We didn't want to surgically intervene unless indicated. And once the vision dropped, there was a indication for surgery, and that's when we took up the patient. So until the vision was good, we wanted to manage conservatively.
Okay.
Thank you, dear judges. Thank you, Dr. Shruti, for once again a brilliant presentation. Many congrats once again to you for reaching the finals. Next, we'll move to the last presenter of the day, Dr. Ahan. Yeah.
Good evening, sir. Good evening, respected judges. I'll start.
Yes, Dr. Ahan, please.
You can share your screen, Dr.
Yes. So, good evening, everyone. Intraocular foreign body, a blink away from disaster. Why the name? Because as per the statistics, intraocular foreign body contribute to 18 to 41% of all open globe injuries. They are mostly foreign bodies damaging the posterior segment in up to 88% of the injuries, and 80% of the accidents occur while hammering. These are the studies for the reference. And so a 25-year-old male comes to ophthalmology OPD with complaints of sudden onset gross diminution of vision following history of something going into the eye while hammering a chisel over stone earlier this evening. The diminution was associated with pain, redness, and watering, and the patient was referred here for the same. There is no history of wearing any protective glasses or equipment. No history of any treatment elsewhere, and no history of any discharge from the eye whatsoever. General examination was within normal limits, so was the right eye examination. However, left eye visual acuity was just perception of light present. We'll see how that falls into place. So the eyelid had a lower lid laceration at 7 o'clock, just behind which there was a conjunctival laceration obscuring a corneoscleral laceration of approximately size 3 mm cross 3 mm. Left eye also showed an iris defect behind the laceration, and which was obscuring a focal lens opacity. So this is the right eye image, and the left eye image as shown here shows a corneoscleral laceration here. There is an iris defect, and there is a characteristic sectoral wedge-shaped opacity because of the lens hydration, probably due to ALC breach. Fundus examination, there was no view because of VH and probably lens hydration. And pertaining to the characteristic wound tract, the diagnosis of left eye open globe injury, suspected type C, grade 4, pupil negative, zone 1 and 2 was made. Imaging confirmed the presence of a metallic foreign body as the Hounsfield units were 3000. Imaging otherwise was within normal limits. The patient was promptly taken up for emergency repair after explaining the prognosis. And as you can see here, the lens has been hydrated fully by this time. The patient was also given intravitreal antibiotics, vancomycin and ceftamycin, along with IV antibiotics prior to the surgery. Post-operative gentle B scan here, you can see there is a highly echogenic foci with comet tail artifact and acoustic shadow, thus again confirming, indicating a metallic foreign body. This video demonstrates the PPV surgery done for our patient. So this is the secondary repair ports are being introduced. A continuous curvilinear capsular access was done with an intent of placing IOL and sulcus in case the ELC breach causes problem in the back placement. Vitrectomic cutter is now being used for lens aspiration. The lens has been fully hydrated, and following which we are getting view to the posterior segment. Foreign body is nicely seen in the anterior inferior vitreous with posterior blood clots being made out. So promptly PVD induction is being done here now. And the posterior pole is now visible. Peripheries are screened as well to look for any breaks. And the foreign body is gently retrieved using magnet. You can also notice that there is a submacular bleed secondary to trauma. A fact to be noted is 20% or more of these lesions have 2 or more retinal lesions, probably to ricochet, which is the expected mechanism in our patient. So the foreign body damaged the macula and then lodged in the anterior inferior vitreous, thus causing the submacular bleed. Is what Mester and Kunt have also shown in their 2000 study. Now, bimanual technique is used and the foreign body is gently retrieved. The port site involvement can cause retinal incarceration, thus managing the patient with promptness. So to summarize, I'd like to say that despite the poor prognosis of increased foreign body size, mass, and visual acuity of just PL plus with a foveal lesion, we were able to give a vision of 660 to the patient by properly following the protocol, clinical diagnosis, classification, followed by image-based confirmation, and the delay in secondary repair helped us in the team and equipment assembly. Counseling follow-up was done and the patient was satisfied with the treatment later. Thank you.
Thank you, Dr. Han. Can you stop sharing your screen?
Yes.
Vasanta ma'am, your comments, ma'am.
I just remember our giant magnet, how we used to remove the foreign body.
Yes.
It was a good presentation and good
Thank you.
management. There's nothing more to add.
Thank you. Thank you, Vasanta. Yeah, Ahan, you are about to say something.
Just that delayed endophthalmitis is not a consequence which we may worry about because the foreign body has already been sterilized by the friction generated in the heat while hammering the chisel. So with IV antibiotics and intravitreal antibiotics, the patient had a successful follow-up as well.
Correct, doctor. We also never used to see infection with this type of foreign body.
Yes, thank you.
Because they say no, the metallic foreign body travels with high speed, so a heat is generated around it and it gets auto-sterilized. So that's the reason why we don't find much of infection in metallic foreign body. Well-managed, good presentation.
Thank you. Thank you.
Yeah, very good presentation and managed very well. Usually infection is commonly seen in vegetable foreign body.
Yes, ma'am.
Not,
Vessel series.
yeah, not in metallic foreign body.
Yes.
Thank you. Thank you, dear judges. Thank you, Ahan, for a brilliant presentation again. So as we have come to the close of this marathon webinar, dear judges, Dr. Karthik and Dr. Pranesh will be connecting with you for the results so that we'll be able to announce it live as well. So before we announce the results, a few formalities to be carried out. So we would like to thank our sponsor, Elazar, once again for supporting us with this initiative of NOI NAADI. Thank you, Elazar. So we are playing their video, which is a 40-second video. So once again, Dr. Karthik and Dr. Pranesh will be connecting with you, dear judges, for compilation of results before announcement. And we'll be having a short video of Elazar.
An autoperimeter is too big an investment to make, particularly from my clinical side.
My patients have to travel to another hospital just for perimetry, sometimes to a different city.
Because of these reasons, many glaucoma patients miss out. AVA bridges this gap by being a diagnostic device for glaucoma with the accuracy of gold standard perimeters at just 1/5 of the cost. Take one step towards expanding your ophthalmology practice and delighting your patients. Sign up for a demo today.
Thank you, Eleazar. With that, I would like to welcome our UC past president, Dr. Digvijay sir. Digvijay sir, warm welcome to you, sir.
Thank you, Ramesh. And I think it was wonderful to see the session today. I think the judges gave some very pertinent comments, and I think there's a lot to learn. And of course, today I could see inputs from all the sessions, unlike the one that I was only part of yesterday. But very good moderation by all of you. I think wonderful presentation by all the speakers, the presenters, very good slides, and I think this is going to, we've generated great content here that I'm sure is going to benefit everybody. And of course, no matter who wins, I could see yesterday also when I was scoring that they were all very, very close. Huh? All your marks, one mark here, one mark here. So frankly, it's very, very difficult to differentiate. And I'm sure the judges will agree with me on that. But all of you are winners, and this is indeed been a wonderful session.
Thank you, Digvijay sir. Sir, with your presence, we also have the GSI president with us, Dr. Satyan Parthasarathy. Sir, so we would like to distribute the certificates under your presence, Digvijay sir.
Yes, of course, under Dr. Satyan's presence. How are you, sir?
All good. Thank you so much. It was a wonderful session. I really enjoyed. I didn't switch off my phone. So it was really nice. All case presenters were excellent. Everything was so different, and I could learn a lot of things. So the learning never ends, and I think all our colleagues, they did a wonderful job. So I was really happy that Prasanna didn't make me a judge. It could have been a very difficult choice for me to do so, because every presentation was unique, and I'm really happy for wonderful presentations.
So UC looks up to you for guidance and mentorship, and I think you've been somebody who's very so much involved.
Absolutely.
Training the young ophthalmologists quite a bit. So I think there's a lot we learn from you. Thank you for doing that.
Surely, sure. We are there always with you. And actually, what is that important thing for me is when we join with the young colleagues, we also feel more energetic. I'm really happy to be with you all.
I want to say your energy levels anyway are way above a lot of us.
Thank you, sir. Thank you, Satyan sir, for being there as a chief guest today. With that, I would like to share Professor Vasantha ma'am certificate by Digvijay sir again virtually. Ma'am, a few words from you as the results are getting compiled by Dr. Karthik and Ganesh.
Yeah, delay is because of me. The sheet got deleted. I had so much difficulty entering the marks and then it got deleted. I'm so sorry about that. As Dr. Satyan said, very, very difficult to assess. Everybody should be given the first mark. So it was so difficult, and I'm really happy to have heard all these young people doing such a great job. Thank you for having me in today's.
Thank you, ma'am. Thank you once again for sharing your wisdom and helping in mentoring our young ophthalmologist of POC once again. Next, I would like to call upon Professor Hema Nandini, ma'am, for her closing comments as well as for your certificate, ma'am, by Dr. Digvijay sir.
Thank you all. Thank you all. It was just a wonderful evening. And as Madam rightly pointed out, like all presentations need to be appreciated. Actually, it was very difficult to give the scoring because all of them are worthy enough to be first. So it was very difficult. But anyhow, we enjoyed it, and thank you all for the organizers for giving us this opportunity. Hope to meet you later also. Thank you.
Thank you, ma'am. Thank you once again, ma'am. We are very grateful from Team UC for taking your time and expertise this wonderful evening. Next, I would like to call upon Professor Malarvili, ma'am, for her virtual certificate and her closing comments on NOI NAADI.
Once again, I'll Thanks for inviting me as a judge for this wonderful webinar. And it's all of them did a very good job, excellent presentation. As both the judges mentioned, it's very difficult to choose the best one, all are best. So it is a very difficult task to put marks also. So we also really learned something from this. Yeah, it's a wonderful opportunity.
I think a heartfelt thanks to all the judges and to Dr. Satyan sir also for for taking out time for YOC and for encouraging all the young ophthalmologists through your comments and encouragements. Thank you so much.
Thank you. Thank you. We are going to bribe all the judges.
So with that, we also like to acknowledge all the participants, dear participants. Before that, the panelists, actually the judges of the prelims were the panelists today. Dr. Geeta Bera, ma'am, if any one of the panelists are available, definitely we would like to have your comments as the results are still being compiled. Dr. Geeta Bera, ma'am, Dr. Mohammed Ibrahim Asif sir, Dr. Gunjan, our own past president, Dr. Digvijay Singh sir, who's again here with us today, Dr. Sujit, Dr. Deep Shekhar Das, Dr. Ashraya Nayaka, Dr. Shreyas Temkar, Dr. Sharad Tegde. Thank you all 9 prelim judges. I think you had the tough job of choosing the 10 out of the 30, and here we are with the top 10. And once again, I would like to thank, there are no other panelists to comment. I think we'll move to the certificate of participation by Dr. Nupur Goyal for the piece, the puzzle. Often you will not know it's there. Thank you, ma'am, for your presentation. Dr. Arut Priya for your lunar landscapes, analyzing congenital versus acquired optic disc pit. Dr. Disha Agarwal for your arthritic AON as presenting feature of Takayasu's arthritis. Dr. Gautam R, unmasking the overlap, early Parkinsonism misdiagnosed as ocular myasthenia gravis. Dr. Bijita Deb, sheath in shining armor, Tenon's patch with amniotic membrane graft for corneal perforation. Dr. Raj Shekhar Paul, bubble trouble, a stitch in time. Dr. Keertana Kasi, a tale of 2 hypersensitivities. Dr. Mausmi, waxing and waning pattern of choroidal detachment, post-scleral buckle. And we have Shruti Nayak for retinal hemangioblastoma, striking at the right time. And Ahan Shah for intraocular foreign body, a blink away from disaster. So that brings us to the close. And so, dear judges, and of course, our chief guest and Digvijay sir. So Dr. Karthik will be sharing the top 10. So we'll go from the bottom. So the results has been compiled, and Dr. Karthik will be sharing it individually to all the 3 judges, Dr. Digvijay sir and Satyan sir. So Digvijay sir, we'll start from you. You can call number 10 and number 9, sir. We'll go from the bottom, sir, if it's okay with you.
Okay, yes, just a second.
Yes, sir. Once you are ready, sir.
But again, like I said, there is no bottom. Everybody is right at the top.
Just for
But
the hype of it.
I think in 10th place I have Dr. Ahan, who also presented very well in my session yesterday.
Dr. Ahan, are you there? Yeah, we have 10.
Yeah,
we have before sir announces the 9th prize, we have all 10 prizes, and President Divakant sir has announced it will be distributed at YOCCON physically. So we have all 10 prizes, sir. So Digvijay sir, all 10 are winners actually.
Perfect.
So that's the president's announcement. So there are all 10 winners today. It's just that we have to conclude with one single winner. So we'll go from 10 on top. Yeah.
And number 9 we have Dr. Disha. Again, wonderfully presented. I think we got to see 2 cases from you earlier. So these are the last, the ones 9 and 10 position. Yeah.
Yes. With that, shall we call upon Dr. Hema Nandini ma'am? Hema Nandini ma'am, can you announce the results of 8 and 7, ma'am?
So number 8 is Dr. Gautam and Arut Priya. Number 7 is Arun Priya, Dr. Priya.
Congrats, Dr. Gautam and Arun Priya. Thank you, Hema Nandini ma'am. With the same suspense, Malarvili ma'am, can we have 6 and 5 from you?
The 6th plate goes to Dr. Raj Shekhar and 5th is for Dr. Shruti.
Congrats once again, guys. Shruti and Dr. Raj, are you there? Yeah. Okay, with that, Vasanta ma'am, can we have the number 4 and 3 from you, ma'am?
Number 4 is Bijita and 3 is Kirtana.
Dr. Vijita, Dr. Kirtana, are you there?
Yes, I'm there.
Congrats once again. And I think there is a little bit of suspense. I think Satyan sir, over to you for our chief guest of the day for 1 and 2 announcements. It is we can take the honors, sir. Announcer.
Okay. Who wants to be number 2? Nobody wants to be number 2. Everybody wants to be number 1, right? So, any clues? Okay. Anyway, both of them they did a great job. So the number 2 is going to be A, B, C, D, F, G, H. Dr. Mausumi is number 2. And obviously the winner, you know that. Okay, Dr. Nupur is the winner with the number 1 position. So great job, all of you. Excellent job. And I wish that, everybody did a great job. And as we teach the presentation skills, if you all can go to the YouTube videos, because I use only Apple device, so I can just say, go to the keynote presentations, how to do. There are a lot of clues that you can take it. So your presentations will further improve. So that is one thing which I sincerely feel all of us have to really go and see how the presentations can be made. Though all of you have done a great job, but I think there is always a scope to improve on all our presentations. Every day there's going to be a new challenge for us. If our presentations are going to be in the next level, people will start appreciating us more and more. So once again, a hearty congratulations to each and every one of you. Thank you, Yosef, for the great opportunity for me today. Thank you.
Thank you, Satyan sir. With that, I would humbly request all the participants to switch on their camera. So we have our very own dynamic Yo newsletter. We would definitely like all of you to feature in that. And we have this classical Yo symbol. With that, we would definitely love to have a photograph with all the participants, judges also. Please, if you can, definitely we would like to have you as a young ophthalmologist of YOC. Dr. Karthik, Hema Nandini ma'am.
I'm young Prasanna.
Yes, sir. We know, sir. And Dr. Gautam, Dr. Fazil. I think we have Mr. Rajesh, and the winner has joined us, Dr. Nupur. Sir, I think you can announce to the winner also. She just joined again with the symbol.
Oh, okay. Hearty congratulations, Dr. Nupur.
Thank you. Thank you so much. So sorry I had to
Do the cooking.
Once again, 3, 2, 1 with the symbol.
Yes.
2, 1. Nupur ma'am, symbol ma'am. Yes. Yes. So thank you, dear all. With that, we have a very formal vote of thanks. Karthik, do you have anything else to add before we move to the vote of thanks?
Yeah, I just want to thank our chief guest Satyan sir and the judges Vasanta ma'am, Hemanandri ma'am, and Malarvili ma'am for presiding this session. And I want to thank Digvijay sir who came and helped in the certificate distribution. And I want to thank Dr. Prasanna, who was very instrumental in making the flyers, and Dr. Niranjan, who couldn't join us now because of the he's going to become a father soon, so he couldn't join. And Dr. Pranesh, who is the mastermind behind the scoring and all the technical work. And thank you. I also thank the OC President and Secretary for giving the opportunity for us to conduct. Thank you.
Thank you, Kathy, for finishing the vote of thanks. And we will also have few more people to thank. Of course, I would like to start by thanking Digvijay sir. Thank you, sir, once again, on behalf of the NOI NAADI team and the UC Governing Council team. Thank you for showing us the way forward, sir. And to all the senior judges and Satyen sir for being throughout the event. So we would also take time to thank our numerotech partner who has been very instrumental in an effortless seeming of conducting this marathon event. We had 5 hours, 6 minutes yesterday. As Satyen sir was telling, did you guys all see the UP yesterday or not in a very lighter way? But numerotech was very instrumental in making sure there was not a single glitch in 5 hours, 6 minutes. And I think we are 2 hours, 11 minutes into play today. Thank you, Numerotech team, for being there. And also, I would like to thank Eleazar, our sponsors. Thank you, Eleazar. We have, I think, Mr. Rajesh from Eleazar. Thank you, Doctor. Thank you, Mr. Rajesh, for this. And if I think with that, we would like to wrap it up. And can we go off live, Numerotech team? Yeah. I think, Manjula ma'am, Sai sir, can we go off live? Yeah. Before we go off live, any participants would want to share your experiences or feedback? We are still live. We can take this time to share your experiences. Nupur ma'am, you are the winner of 2.0. Your experience.
So thank you so much, Dr. Prasanna. It's come as a surprise to me. Sorry, I had to log off in between. So I think it was such a wonderful event, and having all the senior judges, I think the discussion was so nice that it made me also think. So thank you all the ma'ams for all those insightful questions and making us also think so much. And that's the whole point of presenting a case, and that is where all the experience counts. So thank you, Satyan sir. And I think it was a great show yesterday and today. Fantastic job by the entire NOI NAADI team. All 4 of you, kudos to you guys. I'm sure that you must have worked so hard, but it seemed so effortless on screen. The live thing seemed so effortless. That's my first thought when I was thinking about NOI NAADI. Just it is such a flow. Great job, fantastic job. Thank you so much, and keep having this. Keep it like an annual or a biannual event for sure. It's a fantastic initiative.
Thank you, ma'am. Dr. Mousmi, you would want to share any of your feedback?
For all the appreciations from Nupur, I think you must give the prize to her.
Sure, sir. Done, sir. Dr. Mousmi, the runner-up of NOI NAADI 2.0. Your words,
Yes,
we
sir.
would definitely like to hear you.
I would like to thank all the judges, and most importantly, I think the variety of cases which were displayed, that is something it's very difficult to judge, and I think it's difficult to judge because everything comes from a different stream and different subspecialty. So kudos to the judges for making such a decision, because I know it's a very difficult decision to make. And thank you to everyone for just as ma'am told, the insightful inputs which you people gave. So thank you so much.
Dr. Keertana, our third place, second runner-up. Are you there? Yeah.
So I didn't really expect this, but it was a great experience. It was a wonderful opportunity to present also and to listen to all the seniors give their opinions, their feedback. It was a very enriching experience. I really enjoyed it.
With that, we have our top 3. Any other participants? Dr. Vijita, Dr. Shruti, Rajshekhar, Aruppriya. Anybody, if you are still there around, Dr. Gautam or Dr. Disha, anybody wants to share your experience before we wrap up?
Good evening, sir. It is a very nice learning experience over the past 2 days, sir, to see a variety of cases, to learn from the experts, and we also learned how to present case. So it was a very nice learning experience for us. Thank you.
So thank you, Gautam. Any other participants, if you have nothing more to add, we'll close the meeting. Wish you all a good night. Thank you again from Team NOI NAADI. Yes.
Okay.
Bye.
Thank you, sir.
Thank you.
Thank you.
Thank you. Bye.